So our first speaker is Dr. Lucy P. Thaliat. She will be talking about childhood cataract, magnitude and impact. She is a consultant pediatric ophthalmologist in Puttilat Eye Hospital.
Good morning. First, I would like to thank KSOS and Dr. Naveen for giving me this opportunity. Childhood cataract, magnitude and impact. Childhood blindness is one of the priorities in Vision 2020, the right to sight. Children who are blind have to overcome a lifetime of emotional, social, and economic difficulties which affect the child, the family, and the society. Loss of vision in children influence their education, employment, and social life. Childhood cataract blindness presents an enormous problem of human morbidity, economic loss, and social burden. It is estimated that there are 1.4 million blind children in the world. Two-thirds of them live in the developing countries. The causes of blindness in children vary according to the region and the socioeconomic development. Various studies among the blind have reported pediatric cataracts as one of the leading but treatable cause of blindness. Approximately 70 million blind person years are caused by childhood blindness, of which about 10 million blind person years, that is 14%, is due to childhood cataract. Cataract in children may be congenital or acquired, unilateral or bilateral. Over 90% of cataracts are congenital or developmental. Congenital cataract is any opacity found within the first few months of life, and developmental cataract is cataract spotted in infancy and in early childhood. Congenital cataract produces form deprivation or amblyopia and results which affects the child's educational and psychosocial development. In particular, congenital cataract affects more than the bilateral unilateral cataract affects more than the bilateral cataract. Congenital cataracts have a better prognosis if identified early and surgery is done before 6 weeks, at 6 weeks. And developmental cataract has a better prognosis than congenital cataract. The diagnosis of cataract is incidentally made on routine screening in 41% of the cases, whereas leukocoria and strabismus lead to the diagnosis in 21% and 19% respectively. Factors that influence the surgical outcome adversely are the presence of unilateral cataract, nystagmus, strabismus, and any ocular defects like microphthalmos, PFV. Functional results after pediatric cataract surgeries depend not only on the anatomic success of the operation and postoperative maintenance of a clear visual optical axis, but even more on the aphakic visual rehabilitation. Children with aphakia or pseudophakia may develop amblyopia as a consequence of visual deprivation, anisometropia, or strabismus. Coming to the global prevalence, cataracts are estimated to be present in approximately 1 to 15 in 10,000 children worldwide, accounting for 5 to 20% of childhood blindness. A study this is from the global prevalence of childhood cataracts varies from 0.32 to 22.9 and median of around 1.03 per 10,000 children. This is an analysis done by Sheila Devi based on many studies done in different parts of the world. Globally, about 2 lakh children are blind from bilateral cataract worldwide. Around 20,000 to 40,000 new cases of bilateral congenital cataract are diagnosed every year. It has been estimated that over 21% of world's blind children owe their impairment to cataract, and cataract is a leading cause of childhood blindness in developing countries. The incidence varies from region to region and according to the socioeconomic development. In developing countries, the percentage of congenital cataract is more than in the high socioeconomic countries. This is a world map showing congenital cataract as a proportion of childhood blindness. You can see in the higher socioeconomic developed countries, the USA and UK, the percentage is less than the low developing countries. This is a meta-analysis done in Asia using many studies done in the countries in Asia. You can see the prevalence in the various countries. And coming to the Indian scenario, in India, approximately 10% of childhood blindness is caused by cataract, and half of the childhood cataract in India are known to be idiopathic. The same journal which was discussed earlier, so this is a prevalence within India, and it varies from region to region. And why is it important to know the prevalence? It is imperative to have a reliable estimate of prevalence and epidemiological nature of pediatric cataract to develop an effective prevention strategies, implementation of public health initiatives, and provision of improved eye care facilities. Thank you.
Thank you, Lucy, for that extensive presentation. Now I would like to invite Dr. Naveen. He is a consultant pediatric ophthalmologist at Purple Eye Care Hospital, Chavara.
Good morning. In my talk, I will be talking mainly about the etiology of pediatric or congenital cataract and how a pediatric cataract or pediatric eyes is different from an adult eye. So, in the etiopathogenesis, the causes for a congenital cataract is multifactorial, but the main mechanism behind the congenital cataract are oxidative damage, genetic alterations, or metabolic alterations. So, keep this in mind in the upcoming slides. We can classify congenital cataract in many ways. One way of classification is based on the laterality. So, it can be bilateral or unilateral. The cause for bilateral cataract is extensive. So, like Dr. Lucy told, most of the bilateral cataracts can be idiopathic. So, other causes for a bilateral cataract are maternal infections like torch infections, then metabolic and systemic disorders like galactosemia, diabetes, Lowy syndrome, Alport syndrome. Then any ocular malformation or ocular syndromes like anterior segment dysgenesis, aniridia. Any chromosomal abnormality which causes genetic alterations like Down syndrome. Then isolated hereditary where no other systemic findings will be there, and it's usually autosomal dominant. Then another cause is treatment induced or iatrogenic, like the patient is on steroids or had a radiation exposure or after any after retinal surgeries. Coming to the unilateral cataract, the bilateral cataract, idiopathic comes first. Then other common causes are trauma in childhood. Then secondary we have like chronic inflammations like uveitis or retinal detachment. Ocular malformation also comes in unilateral cataract like persistent fetal vasculature or anterior segment dysgenesis. Then treatment induced like steroids, radiation, etc. So, as I said, idiopathic forms more than 50% of the congenital cataract. Some associations are any insult during in the antenatal period like maternal preeclampsia, multiple pregnancy, placental insufficiency, or any drug intake during that time. Low birth weight is also an association. So, the pathogenesis they say is the prenatal oxidative stress which causes exhaustion of the glutathione. That may be a possible association. In the genetic mutations of the genes which code for these lens proteins like crystallins are commonly described genetic pathology. It can be autosomal dominant, autosomal recessive, or X-linked. In maternal infection, as I told before, torch like toxoplasma, rubella, cytomegalovirus, herpes, and even syphilis can cause congenital cataract. In developing country like ours, rubella is commonest. So a virus, it can affect the infection can happen in the first trimester or later in the trimester. So if it's in the early in the early trimester, so the virus can enter to the developing primary lens fibers, and it can cause interfere with the protein synthesis, which lead to the cataract. In the last trimester, the infections rarely reach the center of the lens, but still it can cause cataract by metabolic disturbance. This is a case of congenital rubella. You can see a membranous cataract with fundus showing salt and pepper retinopathy. In the metabolic and systemic disorders, usually such cataracts are bilateral and often have characteristic appearance, and the children will have other systemic involvement, and cataract may not be the presenting symptom. So common causes are galactosemia, diabetes, Wilson, hypoparathyroidism, Alport, and Lewy. This is a typical sunflower cataract seen in Wilson disease. Cataract can also be associated with chromosomal abnormalities, like Downs is a common association. This is a Down syndrome child. In the ocular malformation, anterior segment dysgenesis is a common cause, and here you can see a Peters anomaly. Another common cause, especially in a unilateral cataract in infant, is persistent fetal vasculature. Here you can see prominent ciliary process and an ultrasound showing the stalk. The hereditary cataract can be isolated where it's a non-syndromic, and you can see a family with cataract history. In the acquired causes, we have trauma as one of the common cause. Here what happens is that trauma causes damage to the lens capsule, and which causes hydration of the lens fibers, or it can affect the metabolism, leading to cataract development. Also, chronic inflammatory pathologies can cause oxidative damage, leading to cataract. Long-term steroids can affect metabolic alteration and osmotic failure, thus resulting in cataract. And then we have surgery or iatrogenic cause. So here you can see a traumatic cataract. The left one is a penetrating injury, and the right showing a rosette cataract after a blunt trauma. This is a case of juvenile idiopathic arthritis with pupillary membrane, and the other eye showing thiazical changes. So a few slides on morphology. Because of the layered development of the lens, the timing of the intrauterine insult can be judged by the location of the opacity. If its insult is very early, the embryonic nuclear cataract may happen, or if it's little late, it can affect the fetal nucleus. And also zonular cataract may be, the insult may be little late or in the childhood. Polar cataract are usually suggesting congenital onset. These are a few slides regarding the morphology. Upper slide you can see zonular cataracts, then cataract pulverulenta. We have anterior polar cataract, oil droplet sign, then posterior polar cataract. We have sutural cataract. So this morphology will also help us in giving clue regarding the association. Like in case of anterior polar cataract, we can think about anaradia or anterior segment dysgenesis. Oil droplet cataract seen in galactosemia. This is a lamellar cataract, which is a common congenital cataract. You can see a clear center, and this is a nuclear cataract where the nucleus is affected. This is a blue dot or a Serlian cataract. This is a copper cataract or central pulverulent cataract. And we can see the oil droplet reflex in an anterior lenticonus. So about the pediatric versus adult cataract, like pediatric eye is not merely a miniature of the adult, it's a system under evolution. So as you know, the eyes are hyperopic in the early period, and shift to myopic around 7 years. So the axial length increases significantly from birth to adulthood. But there will be compensation by the cornea and the lens, which is known as emmetropization. But this compensation is lost in post-surgery patients, resulting in significant myopic shift. As you know, the axial length increases, but the power of cornea and the power of lens decreases as the child grows. So the pediatric eyes are small and they have scleral rigidity is very low. So we need to suture the wound. The anterior capsules are highly elastic, so the rexus can run out. The lens is soft and the vitreous is well formed. And post-op, we will have severe inflammation because of the immaturity of the blood aqueous barrier. The chance for posterior capsular opacity is very high, and the eye is evolving, so the refractive status is constantly changing. The risk for glaucoma is high, and there is risk for amblyopia. This is a case of posterior capsular opacification. So to conclude, etiology of a pediatric or a congenital cataract is multifactorial. Still more than 50% is idiopathic, and based on the laterality, location and morphology, we will get clues regarding the etiology and time of insult. And pediatric eye is not a miniature adult eye. This is my reference. Thank you. Next, we have Dr. Saumya Nampiar. She is the consultant pediatric ophthalmologist from Com Trust. Ma'am will be talking to us about evaluation and decision making in the management of congenital cataract. Over to you, ma'am.
So first of all, thanks to KSOS and thanks to Dr. Naveen for having given me this opportunity. And good morning, everybody. So this is one of the most controversial topics in pediatric ophthalmology, how to manage a pediatric cataract. And as Naveen has already told, pediatric cataracts are not the same as adult cataracts. So let's see what are the things that we have to think about. So we know that the global prevalence of congenital cataract, as Dr. Lucy and Naveen has already told, that it's around 2.2 per 10,000 and 13.6 per 10,000. Now, why do we need to identify these cataracts? So we need to identify pediatric cataracts at the earliest. First of all, it is to reduce the visual disability. We need to identify the child at the critical period, because you missed that critical period, you're making the child blind for life. And detection of the cataract at the earliest not only helps in giving that good vision to the child, but also helps in a gross motor and fine motor development in the child. And definitely it is an indicator for an underlying systemic conditions which can be identified earlier on and treated at the earliest for the child. So as Naveen has told, the most common cause is idiopathic, 62% literally. And inherited causes are around 22.3%. And non-hereditary causes, as you can see, involves the metabolic, traumatic, infectious causes, and cataracts which are associated with syndromes, which accounts for around 11.5%. So as he has already told, what is the importance? So first of all, in children, you're not going to get any kind of details from the child as such. So you need to have a elaborative history from the parents. So you have to ask them what is the age of the onset, whether there has been an antenatal, natal or postnatal history, like there is a hypoxia or a hypocalcemia at the time of birth, there is any injury at the time of birth. All this has to be asked in detail. A family history of consanguinity is very important. As he has already told, autosomal dominant ones are more common. So you have to check the parents also when you are evaluating a child. and what is the vision of the child, whether there has been a history of frequent falls, because sometimes you may not get the history, so you can always ask whether the child is falling in a condition where there's a well lit conditions and the child is going on falling. So that could be one of the history that you're getting. And any developmental history, any history of drug intake, like in case of nephrotic syndrome, the child is on steroids for a long time, and that could induce a cataract, and systemic symptoms that is there. So always examine the child in whole general physical examination is mandatory. And in all of the like bilateral cases where you have systemic associations, always send for a pediatric consultation. You may detect some cases, like in case of a rubella cataract, you may have a heart anomaly that is associated, so that can be detected by the pediatrician better. Look at the head circumference. Sometimes you may have a microcephaly along with that. And examine, as I told, examine the family members. This should not be missed. You may have a subtle cataract even in the parents. Ocular examination is very important. Visual acuity has to be checked. A simple fixing and following light will help in knowing what it is. And resistant to occlusion. You can see that in case of unilateral cataract, the child is preventing occlusion of the normal eye. And Bruckner's test is a very, very important and a very simple test. Just look at the red reflex. See if that opacity, that red glow is not there. You know that there is some problem happening in that part. It could be a lenticular problem. It could be something which is behind also. But definitely it will give some red flag signs that you have to look carefully. And preferential looking, as you know what you do in the infants. Now, some cataracts can wait. So you can, usually you see that the cataracts which is less than 3 mm in size, we tend to wait. But more than the size, I feel the more denser the cataract, the more amblyogenic or more problem it is causing. The more posterior the cataract, it's more problematic. That is more involving the nodal point. It's going to cause more problem. So certain cataracts, like as he has told, the Mittendorf's dot, like this, you can wait and watch. Anterior dot polar cataract. But remember, in an anterior dot polar cataract, you have to look for anisometropia. It may not be amblyogenic, but anisometropia could be associated in these conditions. So these are the conditions when wherein you can, maybe in the central point, you think that the child is very small, there's a small amount of cataract, you can just manage with a plain dilating drops, like a tropicamide. For the time being, till the child is ready for an anesthesia, till the child you can take up for cataract. But again, you have to remember that follow up this child very closely. They may progressively increase. So that is very important. Don't let them off that, okay, it is a small cataract, nothing is going to happen. They may progress. So you have to be very careful. Even the blue dot cataract, which is seen in Down syndrome, they may be amblyogenic. You have to follow them up. They may progress to a total cataract also. Then needs intervention, as I have told, more than 3 mm in cases of these lamellar cataracts and embryonal cataract, you may need to interfere at the earliest. Persistent fetal vasculature is one of the most complicated type of cataracts. Ma'am will be talking about it, I suppose. And it can present in varied ways, like these retrolental membranes. Whenever you see the ciliary process, the vascularity developing, you have to be very careful. Look at the eye carefully. There may be a microcornea associated. Usually these are unilateral kind of cataracts. And you have to be very careful because they are commonly associated with glaucoma as well. So, always see if the child is having strabismus, nystagmus with cataract, the cataract is visually significant and you have to intervene at the earliest. Always check the intraocular pressure. You have to rule out glaucoma, like how I told in congenital rubella, it may be associated. Don't ever hesitate to take the child under anesthesia to evaluate it. Okay? Sometimes the evaluation may be done just before you're planning a cataract surgery. Remember to look at the pupillary response. It's very difficult to get in a child, but it definitely helps in ruling out any retinal or posterior segment causes. And a direct and indirect ophthalmoscopy examination is important to rule out the posterior segment abnormality. Whenever you see a cataract, if you're able to see the fundus, so if the cataract is not very dense, most of the time you'll be able to see the fundus. Then you can tell whether there is any pathology or not. But in other cases, you may have to go on to do other investigations like B-scan and all. Then lab investigations, the routine blood and routine investigation, complete hemogram, the blood sugar and urine microscopy has to be done.
and other tests based upon the type of cataract you can order. Okay, and that already Naveen has already told about it. So as I told, a B scan is mandatory. Two things that it helps: one, in dense cataract, it will help in knowing if there is any retinal pathology. Other thing is, it also gives you an axial length. So if you're not able to get an axial length in a child, it will help you to know the axial length as well. And ultrasound biometry and handheld keratometry usually is done at the time of the EUA. Then the recent advances, that is genetic research, is the recent thing that has come forward. So basically, it's been found that more than 100 genes have been identified in congenital cataract. And as he has told, most of the cases are idiopathic, but we do not know. We have not done a genetic analysis for most of it. A non-syndromic cataracts could have a mutation of crystalline proteins, like what he told about connexins and all. So just remember that 100 genes have been identified. So there may be some association like that. So these are the various genetic tests that have been are being done nowadays, and the cost factor is also reducing in this time period, the NGS and the whole exome sequencing. And this cat map, which I have written in the end, it's a database which tells each loci of the cataract, where it is and what type and syndromes that is associated. So this could give an idea of the gene that is involved. So this is a database that is freely available. So a prenatal diagnosis. So if you have this diagnosis, you can always use these non-invasive methods and prenatal 3-dimensional ultrasound to detect if the child in utero itself is having a cataract. So now, when to operate a congenital cataract, whether to do early or whether to do late. And early surgery is always associated with some anesthesia complications and the problem with glaucoma. While in a late surgery, it will cause more of stimulus deprivation, amblyopia. So what is said is that every additional week of age will reduce glaucoma risk, but will increase the risk of stimulus deprivation, amblyopia. So we all know that there is a lot of controversy in pediatric cataract. Okay, so what has happened is there are not much of clinical trials that has been done in a congenital cataract. So a modified Delphi approach was adopted. Now, what is this modified Delphi approach? So basically what they have done is they have got all experts who are good at pediatric cataract. These experts, they have given some set of questions to these experts, asking what they do in certain situations of cataract. And they have got an opinion from these experts. And based on that, they have brought a consensus that this can be done and this cannot be done. Okay, so this is just a consensus. It's not a sure shot thing, but definitely it will give us an idea of what has to be done in early cases. So these experts have come to the consensus where all these things has to be done. That is, early screening has to be done. If it is a unilateral cataract, a surgical intervention has to be done at least by 6 weeks. A bilateral cataract by 8 weeks at least, okay? And a 1 week gap in between the cataracts. And the surgery option that is usually done is a micro-incision cataract surgery with a posterior capsulotomy and anterior vitrectomy with an IOL. So IOL, when is it put? Whenever the child is more than 2 years. That is the consensus that is brought forward. And you have to see if the corneal diameter is more than 10 mm and an axial length of more than 17 mm. PPC with anterior vitrectomy has to be done at least till 4 to 8 years of age. Beyond that, if the child is cooperative, you can go on for a YAG capsulotomy. But note the point that multifocal or toric lenses were not recommended. Okay. And what is the consensus of secondary IOL implantation? That is, you have done initial surgery, you have left the child aphakic, and when do you implant a IOL? By 4 to 8 years of age, in cases of children who were contact lens tolerable, in those cases, you do a secondary IOL. And it can be done even early if they are not ready to wear contact lenses, if they are coming from very far off places, or some syndromic child, but has a development of the cornea and this thing has occurred. An iris claw lens with no capsular support can be used. A silicone contact lenses is usually used in a child who's aphakic but less than 3 years. no consensus was still, in spite of asking these experts, there was no consensus regarding these following things. That is, IOL implantation in children younger than 2 years. So there was a meta-analysis which showed that if you implant primary IOL in less than 2 years, they had a better visual acuity if when compared to a group which were aphakic and had contact lens wearing. But they had increased chances of posterior capsular opacity. And in that group, it was seen that the prevalence of glaucoma and strabismus were similar in both groups. But what they recommended is when you are putting an IOL, it has to be optically captured or it should be a bag in the lens type of IOL. And they also said that even in these less than 2 years, IOL implantation should be delayed if there is microphthalmia. And the consensus again was not there if what type of IOL material has to be used. So most often what we use is hydrophobic acrylic. But hydrophobic acrylic, the problem is that it has got this kind of glistening to the IOL. Okay, so there is no consensus. I'll just use 2 more minutes. There is no consensus like these glistening will cause reduced visual acuity. So the trial was not done regarding that. And the power calculation, usually we use Holiday 2 and SRKT, but which is correct has not been still got. And it's been found that less than 50% of children in 5 years of follow-up had found to have were within 1 diopter of target refraction. That is, you know that a hyperopic after doing a pediatric cataract surgery, there will be a myopic shift. So you may tend to make them more hyperopic. Okay, but at 5 years of follow-up, less than 50% were found within 1 diopter of target refraction in those cases. And there was no consensus whether intracameral antibiotics has to be used or not. So post-operatively, refractive correction has to be given. This is as such, post-operatively refractive correction has to be given and occlusion therapy has to be started at the earliest. Watch for glaucoma and strabismus. You need to have a long-term follow-up, may need membranectomy or capsulotomy at a later stage. And these are the factors which will affect the visual outcome, that is the age of onset of cataract, the laterality of the cataract, whether it's associated with the ocular and systemic conditions, and the age when cataract surgery is performed. Adherence with optical and patching therapy is necessary. You have to confirm that with the parents as well. And so what's the take-home message? Congenital cataract is the first step towards management. Always tell the parents this is just the first step. You need to follow up. You need to be compliant with all the things that has been done. Otherwise, a well-done cataract surgery is going to be totally waste. A clean aphakia is far better than a badly done pseudophakia. Occlusion therapy at the earliest, especially in unilateral cases. Better to avoid IOLs in the first stage if corneal diameter is less than 9 mm or associated with uveitis or any other issues is there. And a need for long-term follow-up has to be re-emphasized always. So thank you.
Thank you, ma'am. Now I will call our guest faculty, Dr. Santa ma'am. She is the senior consultant pediatric ophthalmologist in Aravind Eye Hospital, Coimbatore. Ma'am will be talking about management of complicated cases.
Thank you, Dr. Naveen and KSOS for the kind invitation. So I'll be showing a couple of cases of surgery in complicated pediatric cataract. So this is a patient who has a primary posterior capsular deficit. You can see from the video that the edges of the PPC is very clearly seen, the primary PCR. So this can be picked up in slit lamp examination just before the surgery. What I would like to say is if you see the posterior capsular deficit, then don't make a very big rhexis because most often you may not be able to place the lens within the bag. It may be the support may not be good enough. That depends upon the size of the primary PCR. So the size of the rhexis will be around 5 to 6 millimeters. You can do a very gentle hydro or no need to do hydro. You can see the IOP there. IOP is around 20 only. So it is very slow motion aspiration. And because the vitreous is quite well formed in children, it will not drop. If we do a slow motion phaco with low vacuum settings. So I am using a 3-piece IOL here which is injected into the sulcus. You can see the leading haptic going into the sulcus. So dialing the entire thing into the sulcus and then this is the optic capture. So in such cases, you can do an optic capture within the bag or even optic capture into the PPC also you can do. So that way you are not going to get the complications of crowding in the anterior chamber, and so the stability of the IOL will be very good. You can see how big the primary posterior capsule. There is no way of keeping the IOL inside the bag. It will dislocate or drop. So this is what you will do, and sometimes if you have access to UBM, you can even pick out these cases preoperatively. UBM, you can easily see the deficit in even in adults and children, both ways you will be, especially if it is a mature cataract. If you have a doubt, you can see. This is a patient who has a blunt trauma. You can see the zonular dialysis here and the central cataract. So there is a dialysis extending from almost 3 clock hours. So for this limited dialysis, there is we can do CTR placement with in the bag IOL placement. So it will be quite stable. So here again, while doing the rexis, it is very important to judge the size and stability, because we will not be able to again do a double rexis and extend. After putting CTR, it is not possible to do a double rexis. So initially you need to get the size right. And while putting the CTR, it is very important to see that the CTR is going exactly into the bag and not going into the sulcus or somewhere else. After putting the CTR, you can see that the bag has, so that is the correct time of putting CTR, not after you aspirate or so, because that way the stability of surgery is not there. But the only disadvantage is when you put the CTR, the cortex aspiration is going to be difficult. So here I am going with the Simcoe cannula, because otherwise you can use the bimanual. Here again using a 3-piece lens. See, most often I am using 3-piece lenses now, but it depends upon surgeon's preference. In clear cases, if you want, you can use single piece also. So here you can see that the lens is being dialed into the bag. Instead of dialing, I usually flex the haptic and put it inside, because that way your trauma while dialing is less, you are not touching the iris. And there is no need to do a PPC here, because the age, especially after putting CTR, you cannot do PPC. It is going to split the bag. So just make sure of good cortex cleanup and then close the case. This is another case of blunt trauma, where what is the difference? There you saw the cataract. Here the anterior capsule, you can see the rupture here. This whole area, the capsule has got ruptured. So then what to do? Then there is a synechia which has formed here. So you can just go in and aspirate. Again here the IOP should have been ideally lesser than this, because you don't know the status of the PC. No need to do hydro in such cases. Just aspirate. The cortex will be very fluffy and it will come out very easily. Following that, here you can see some margins very well. So it is possible to place the lens in the bag. As far as possible in pediatric cases, the most important thing is in the bag placement. Because once that is not there, in the post-operatively, we can see a lot of pigment depositions and iritis and glaucoma. All these complications come only in cases of PCO. Everything is high when you do a sulcus placement. So as far as possible, it is better not to let the optics or the haptic touch the iris. So here you can see that the lens, whatever bag is there, the lens is there within it. This horizontally, like this area and that area, it has got extended. So you place the haptics in these areas where it can be within the bag. So if you are going to keep the haptic in this orientation, after some time that's going to pop out. So wherever you have the capsule, it's better to keep the haptics there. And in this case, I am doing a PPC also. There is one opacity here which is in the vitreous, so that is not coming out even with the anterior vitrectomy. Anyway, that we cannot go down and take that. So that is some opacity which has come during the blunt trauma. So you see the size of the PPC. In our center, usually we do the PPC after placing the IOL, but that again it is surgeon preference. Advantages of doing this is, it is the IOL is there where you are already positioned it well. Whereas if you do the anterior axis and the posterior axis, then you have to definitely go and open up the bag and then you have to place it. Sometimes it may not happen, but again it depends on how you have been trained and how you are doing also. So that's a surgeon's preference there. So this is a case where there is a complicated cataract with uveitis, and you can see the synechia here. So there is like total all the 360 degrees there is synechia. Only this area there is synechia is not there. So in such cases, it is important to do a PI also, because there is a possibility of post-op inflammation. And here we are releasing the synechia. Thing is, you have to really release it fully. Like sometimes you don't, the synechia may not only be at the pupil border, it may be all around. And since it is an intumescent cataract, not doing a very big rexus here, because it has a possibility to extend. So do the rexus in whatever, even though it is small, you will see that here again, now cutting and doing the double rexus. So this possibility is there, provided you are not placing a CTR or any device inside the bag. It is possible to extend the size of the rexus after aspirating the cataract. That is the only way you will be able to do in a intumescent mature cataracts. Here again, in uveit cases, the very, very important to place it in the bag. Otherwise, it's going to be a lot of inflammation you are going to see. So here you can see the color of the glow itself, that there is a lot of inflammation inside. So this particular patient, it is just that sometimes it is all white. You will not be able to make out the status of the anterior capsule. So in this case, you can see now when I am going it, the rexus is not coming because the anterior capsule is calcified. So in this case, you can come across this scenario. Then what can be done is you can use a microrexus forceps and just cut the capsule. Because if it is calcified, you are not going to be able to do it any other way. So this is like in two areas you can cut it so that it won't extend, and then you can join it also. So that is that push-pull kind of technique which was which are there in some publications. So if you don't go right in the center, you can open in two areas and then you can join it in between. So after aspirating, you will see that you have got a rexus here also. So you can see now. So this is how the capsule was. Only after aspirating the cortex, there is no way you can get a rexus with a cystitome in such cases. Again here, you can now go back and you can increase the size of this. So I think after putting, this is a single piece IOL being injected. After that, you can extend, or you can extend and then place also. So using the microrexus forceps again to enlarge the size of the rexus. So as long as you are working within the area of the fibrosis, it is very safe. It is not going to extend. So you can use the area of fibrosis to your advantage. Beyond that, if you go, there is always a chance of extension. That is why I am doing this after placing the IOL. It is never going to extend because of the fibrosis. So that is the thing here. In all cases, we do PPC up to the age of 10 years because sometimes, most often, PCO happens. And the quality of shots with the YAG laser may not be good. You may get lens pitting if the child is not cooperative, especially if the child is delayed or some other reasons are there. So doing the PPC with or without anterior vitrectomy will solve that problem. Above the age of 10 years, even if PCO comes, you can get a good cooperation with the YAG. So this is a patient who had a membrane. So I'm just telling some cases after aspirating the cataract, you can see it looks like a PPC here. So, and it's also some kind of anterior segment dysgenesis where you can see the iris is not well developed. So here again, after doing the rexus, you always use a, like you pull to the center. You have to use a centripetal rather than a tangential force. And here we always, mostly we go with the coaxial. Only if it is not coming, we tend towards using bimanual. And see here the membrane, and the membrane can be actually picked out and removed with your forceps. So sometimes the membrane is just there. You think that it is attached to the posterior capsule, but it is not. So after that, I am just cutting and extending the rexus here and doing a double rexus and completing the case, and then placing the IOL inside. So there now you see the almost it is so clear. It didn't look like there is a membrane at all. So you can always try that. Just try to remove the membrane. It may come off. If it is not coming, then you can use a cutter to do the membranectomy. So this is what Madam was talking about, the PHPV cases which are usually very complicated because it can be a combination of anterior or posterior PHPVs. So in this case, almost it has like it was really shrunken bag and with posterior synechiae. So trying to release the synechiae here, it is not, and you cannot use a lot of force because one thing, it can cause bleeding. Secondly, the iris can just come off. It can create an iridodialysis. So you have to be very careful, and you see that the bag, the cataract is so small. It is just coming out. It is like fully, you can see the vascularization in the middle, and it is like partially absorbed kind of cataract. So this is like leaving the patient aphakic in this case. Right now, just rehabilitating with the aphakic glasses or so. You can use a cutter also to remove it. So that here, after removing the membrane, I am trying to just dilate the pupil and see what is happening under the membrane. Yeah, just for help to see whether the cortex is there. There is some cortex which is still remaining. So you have to make sure thorough cortical cleanup is very important. Doing a limited anterior vitrectomy in the middle, and this case's PI is very essential. So the important thing is in any complicated case of pediatric cataract is a clear visual access. So he can see the PI which was done here with the vitrectomy cutter only. So you can use the same cutter to do the PI, or you can use a PI forceps also. Very important that the visual axis should be clear. That is the aim of the surgery in any pediatric case, whether you leave it aphakic or with the IOL. This is another case of PHPV. It's a younger patient. So all patients till the age of 2 years, I do a scleral tunnel. Beyond that, we'll decide like whether we can do clear corneal also. But very young patients, scleral tunnel is better because the AC forms much well. Now you can see the extent of the membrane here, and you can also see the vascularization. So after putting in the 3-piece IOL in this case, I am going down under the IOL, and it is not possible to open that with the, so I just made a nick with the side port forceps and then trying to remove the membrane there. You can see that vessel, the vessel is cut now. In case it is bleeding too much, you can use a cautery. The retina people have the endocautery which can be used to cauterize the, it will be a better idea to cauterize it before you cut it also. In case it's a very big vessel, we will cauterize it and then cut it. Here you can see the bleeding has stopped now. This part I left because already again it was very much vascularized. Again, if you remove that, it will create a lot of bleeding, and the visual axis is clear. And that area, if you remove, maybe the IOL also will not be stable. This is a patient with aniridia. So here you can see the small iris stumps only remaining. So aniridia with a total cataract. Aniridia with partial cataract, very early PSCC and all, I just leave it as it is. Only if the aniridia is having total cataract, we go and do surgery, because we are not using any devices for aniridia, iris and all we have not used because of the high risk of glaucoma in such cases, and limbal stem cell deficiency. So many problems are already there. So we don't want to create harm in such patient. So here doing the rhexis and slowly aspirating the cortex, you can see that it is there. A PPC is also there in this patient. So in any case of mature cataract, you need to be very careful. You don't know the status of the posterior capsule and PC. So here now I am putting in this area, it is a good idea to place a CTR in cases with aniridia. One thing is it will give more stability to the bag. Another thing is the incidence of PCO will reduce later on. So it is always better to put in a CTR. And then followed by 3-piece lens injection inside the bag. Following that, we'll remove we have to do that central membrane removal again. So I like this way of putting the lens. I'm very used to doing it this way instead of dialing things inside. The dialing thing is more difficult for me. So earlier I used to use a lot of single piece, but the problem is, since we are doing PPC after putting the IOL, if there is any problem, if the PPC extends, or if there is, it can just split. You can never predict. Then we have to explant the IOL. There is no way the IOL will be stable. That's why again reverted back to 3-piece. And here again you can see that membrane is being removed now. There is actually there is no PC dehiscence. It just came off and I left it. So since the CTR is there, I did not do a PPC in this case. The PC is clear, so we can just leave it. Coming to a case of lens coloboma, this is a patient with a Marfan syndrome. You can see the height and the span, the fingers, and he had all the features of Marfan and also cardiac thing also. Marfan's with a lens coloboma rather than a subluxated lens. So in this case, you can see here all the zonules are intact, but the shape of the bag is very irregular. So in such cases, it is difficult to place the CTR initially because it can just puncture and go out. CTR will go in easily if the bag is shaped in a sphere. In a subluxated case, you can do it, but in coloboma cases, that's why I'm aspirating without putting CTR in the beginning. And then, so how to do it now? You can use iris hooks. You can use iris hooks to stabilize the bag, pull it apart, and then that way the shape of the bag is little better now. Now I will place the CTR. So if you go initially, it can just cut through, create a hole and go through the bag, and it will go into the sulcus. So this way of placing a CTR is safer if you see that irregular bag shape. This iris hooks will provide additional support to your surgery. Now CTR is in place, iris hooks are also there. Iris hooks can be there until you place the eyeball, so that it helps for dilation also. This eyeball again is placed in sulcus with optic capture. So you can do that. So in the end, there is a good centration compared to before. Even in the mid-dilated state, you can see that it is very well centered. This is post-operative day 1. So there is no problem in this case. And usually what happens in such patients with coloboma and all, the cylinder is very high. So even though it is a clear lens, they cannot rehabilitate because the cylinder is very high. So that is why it is better to do the surgery, even though the lens is almost clear. Then coming to subluxation with the Siani placement, I find it's much easier to do Siani with a scleral tunnel because putting every instrument inside is easier with the scleral tunnel rather than clear corneal tunnel. Here you can see almost half and half subluxation. Ideally, it was easier to do in an earlier case, but I don't do till the age of 10. This Siani. It's very, very difficult in younger patients. Incidence of PCO is very high and it really beats the purpose. So at that age, I do lensectomy. But in older patients around the age of 10, can do Siani also. Here you can see that the bag is being stabilized with the iris hooks and aspirating the cortex. And after this, so you have to do the Siani, the tunnel for the Siani in the area of maximum zonular weakness. So in that area, you do another tunnel here. You can see that. So because that's where the ring is going to come, and you are using the Prolin suture which is tied to the eyelet. Single eyelet only I use. Double eyelet becomes very difficult to manipulate. And now I am using this needle. Bent 21 gauge needle which is coming out through the scleral tunnel, and then threading you use the double armed Prolin as double armed only. So then both the things are taken out of this incision and then on tying. You can see now this is the second. So this is why I said scleral. Clear corneal means it is very difficult. Sometimes it will just come in through it will include the tunnel also. So scleral is easier. So here you can see that this eyelet is being tied here, and you can see the bag has stretched. Okay. So now after this, we need to close this incision also. You see here the bag which was here like half and half. It is fully stretched now. Chance of PCO is very less at this age group, but in younger age group, I think this kind of manipulation is difficult because the anterior segment is very shallow. So now the IOL is placed inside the bag, and that is the end of it. I am using Simcoe, just didn't want to create any vitreous disturbance there. So there is no vitreous disturbance at any point in this case. And then you have to suture, you have to make it quite tight. With the chance of post-operative hypotony is always there in such cases, so you have to nicely form the anterior chamber. So that's extremely important. Then just another 2 minutes, I think. We can stop at any point of time. I don't know if the next people are already there. Okay. So this is membranectomy. You can see this can happen in any pediatric case. The IOL is in the bag and there is a membrane. So you just have to explain it correctly to the patient. Don't tell one surgery, one for lifelong thing and all, because the incidence of PCO is very high in a younger age group. Thing is, in a single piece IOL, to lift it out of that bag actually is difficult because it sticks very well to the bag. That's again the 3 piece is easier because there is some spaces there. Whereas single piece you need to, sometimes it's so stuck you think the bag is going to just break and come out when you are trying to lift it to do the like so much of, you can see there is so much. This case was like operated at the age of 1 or so. Within 6 months got a very dense membrane, and now we have created again a PC opening. It only can happen once. It cannot happen more than that. So when you operate on very young children, placing IOL at the age of 1, you need to tell them this possibility is there. Otherwise, they are going to be maybe not very happy. See this case operated elsewhere. Full lens is in the sulcus. Means the lens has been initially placed in sulcus. So after some time, this is what will happen. The pupil capture will happen, PCO will happen, and this is universal if the case is going to be operated at a very young age. So if you are not able to place in the bag, just leave it aphakic. Later on we can place secondary IOL. At least there's no point of, it is almost looking like cataract only. There's no point in doing a case like this. If you are not able to place within the bag, just leave the case aphakic. Take the case, same patient up after 1 year, and you can place secondary IOL. Now you see that so much of, see the amount of synechiae that has formed and so much difficulty because it becomes very, very inflamed. And most of the time when we see the other eye, it will be lamellar cataract and we'll be surprised. It is not a complicated case. Okay, so now I have created a space and put the IOL inside the bag, whatever it is there, not inside the bag, I'm sorry, in the sulcus, and then going underneath and now creating an opening there with the 20 side port blade, and even then just doing a vitreorex, I think, or cutting it with the one of the two things. I think we are running short of time. I have a lot of complicated cases. Every case which comes is complicated. So see, yeah. So you're just cutting it with the scissor, and because if you use a cutter, the cutter cannot be used for any more cases. It will just be totally damaged. This much of PCO, don't damage your cutter trying to do it, because then the sister will be angry with me. She cannot use it for any other case. That's the end of, cutter will die and has to be buried after that. So that's all. Just pupilloplasty if you want to see. This case had an IOL with opacification. This is a pseudophakic case actually, our own case, but got a pupil capture and membrane which happened. And here again, just this case, just trying to show what can happen in very young babies. When if the surgery is uneventful, but this is a in the bag placement, there was post-op inflammation. Probably they have not put the drops well also, and that can create, you never know, because parents think they are putting inside the eye, whereas child may have closed the eye, and then you can do a bit of pupilloplasty also, so that it doesn't happen again. Then go and do the, this is a phakic case with a eccentric pupil where we have just done a, like centered the pupil up a bit. I think that should be enough. Yeah, that's all. Thank you.
Thank you, ma'am. With that, we come to the end of our IC. Any doubts?
Ma'am, I would like to ask you, in all your cases with PC dehiscence or like this, you keep the IOP in the lower level in the 20 range for all the cases like that. Always you start like that. Okay.
You always have to know the settings of machine very well. Where whatever machine you are using, you have to, because sister will not know, you will have to first look there and keep the settings very low, do a slow motion aspiration. Yeah, otherwise it will drop. Yes.